140 people booked for tonight. So thank you for joining on time. I'm going to give it a couple of more moments. Thank you. Thank you. We are going to start now. Whilst we are expecting more people to join us, we do have a lot to get through tonight. So welcome everyone. Thank you for joining us this evening. This is the second of two events, and we're really excited to be talking to local people as we develop and create our integrated care system. Could you move the slide on, please? And we are recording the session tonight, so if you're more comfortable, do please turn your camera off for that. We also would like to highlight that you can put on your own subtitles by clicking on the three dots in the at the top of your screen. And then scrolling down, and you can find the option to enable live captions that will give you subtitles, which might make it easier for some people to take part. Thank you to those of you who submitted questions beforehand, and we will endeavour to answer those in our two question and answer sessions this evening. But do also please put your questions in the chat as well. So thank you, and if we could move on to the next slide. We've got a range of speakers for you tonight from different organisations across the partnership of the integrated care system. We also have two question and answer sessions, which I've just mentioned, and also I just want to clarify that we will have a short comfort break in the about halfway through tonight's session as well. I'd also like to let you know that we will be sending out a copy of these slides and the recording tomorrow with a link to an evaluation. So do please take some time to fill that in as well. Okay, thank you. Before we start, if we could have the next slide, we want to do a quick temperature check of understanding what the ICS is and whether you know what the ICS is. Someone is going to put the link to a quick poll in the chat for you to click on that. Thank you. The do poll is here. You can click on it, or for some people you might need to copy that link and put it in a new browser or a new tab. There are no right and wrong answers to this, but we would like to understand whether you know what an ICS is and what it means for you. So do please take a couple of moments to click on that link and give us a quick yes or no to those questions. So at the moment, we've got 33% of people who know what an ICS is. Oh, that has moved rapidly to 60%. I'm hoping no presenters are clicking on that. And 40%, 29%, that has changed significantly. So at the moment, 71% of people know what an ICS is and 29% don't. That is a really great percentage, so we would hope to move that throughout the session, so we've got a higher percentage at the end, but we're starting at quite a high level there, so I'm not sure. Could we go on to the second question to understand, to see whether people understand what it means for them? If we could just move the response slide on to the second question. Okay.
Sorry, Rosemary, my internet has frozen.
Oh, okay, not to worry, Diane, thanks. Can you stop sharing your screen at this point, Diane, is the question though, so we can go back to the presentation.
Bear with me, I'll just leave that meeting. Apologies.
Okay, thanks, Diane. So already we've run into some online internet problems, so we'll just try and sort that out. Diane is leaving. So just whilst we get the presentation slides back up, I will take a moment just to hand over to Richard Douglas. I think we've jumped a slide there. So we've got Richard Douglas before Andrew Ayres, who is the chair designate for the Integrated Care Board. Over to you, Richard.
Hi there, everybody, and thank you for joining us. So many people joining us at 6 o'clock on a Wednesday evening is great. Welcome to today's engagement session, introducing the South East London Integrated Care System. Now, you've got, we had a little bit at the start of a poll of how many of you knew what we were. I will take the results of that, I think, with a little bit of a pinch of salt at the start, because I think it probably froze at the point that 8 people had responded. So it may well be those numbers will change quite a bit as we go through. But it's great to see so many people joining us today. The ICS is something different than anything we've ever had before in the NHS, and we want it both to be and to feel different to people. It's about the whole being greater than the sum of the parts. Our aim is for us to be a true partnership of all the organisations that contribute to health and care of the population of South East London. Now, that's whether they're GPs, hospitals, local authorities, community health providers, voluntary and community organisations. This is about everyone coming together to improve health and care. And by coming together, we believe that we can achieve something special and truly transform the health of the population of South East London. It won't happen tonight. It won't happen all overnight. This will take time for us to do because we are building something new. But we believe that together we can build something that is great. And that's why today's session is so important to us. It's part of a process, not just of us trying to improve your understanding of what we're here for, but also actually for us to use you to help shape both what we do and how we do it. So you're part of this creation of the ICS, and I hope you are able to take the opportunity tonight to really engage in that. I'm not going to talk for any longer. There's lots of people going to speak tonight, but I hope you enjoy the session. I hope you feel it's been a good use of 2 hours of your Wednesday evening. And at that point, I will hand over to Andrew Ayres.
Richard, thank you very much indeed. And I think we're going to go back to the slides. Fantastic. And a warm welcome from me to everyone who's giving up their time on a cold Wednesday evening. So I'm going to try in the next 20 minutes, along with colleagues, to try and give you the essence of what an ICS will give us in terms of improved outcomes and better partnership working across our health and care system. So if we can just go to the next slide, please. So for many people involved in health and care, whether it's working in statutory organisations like the NHS or councils or third sector organisations, or indeed just in the public who engages with us, working together and in partnership has always been an important part of what we do and has always been recognised as contributing to how we do things well. I think the important thing to say about the ICS is that for the first time, we'll absolutely put it enshrined into through legislation in terms of a formal partnership arrangement across our whole South East London system. And what we want to do in perhaps the next 20 minutes is to try and explain what that kind of ICS partnership working might mean in practice. And we're going to do it through two means. One, we're going to involve some of the people who are working across the system and have been directly involved in care and support to local residents, but also we're going to use the example of the vaccination programme, something that is probably well understood by very many people as a critical part of our response to COVID-19 and really important initiative and program to try and protect ourselves from the worst impact of that. So, and that requires us to work very much in partnership. On to the next slide, please. And so when the government declared a major incident in March 2020, 2 years ago, roughly to today, we knew there's a huge challenge we faced, and we knew we'd have to draw on all the collaborative working that we'd had in the past across our 6 boroughs in South East London, but also importantly within our boroughs and within our kind of partnerships that existed within our local areas as well. And we also knew we'd have to rapidly mobilise new ways of working to respond flexibly, to adapt, and to think about how we do things in ways that we'd never done before, but to do them together and to do them in a way that was coordinated and had the biggest impact for local people. And I was fortunate in Lambeth to be able to draw on the partnership that we've developed over some years, including all of the partners you can see on this slide. So the third sector, our local foundation trusts, Healthwatch, the council, and the CCG, and of course primary care and others as well. So to draw all those partners together, to use all their resources and brain power and assets to think about how we might respond to this pandemic in a way that protects people. And an important part of that was the vaccination programme. All of those partners that you can see listed on there were involved in how we coordinated the way we did our vaccination programme within our borough setting and then more widely across the whole of South East London. And the next person I'm going to introduce you to is Professor Ash Shoney, and he's one of our community pharmacists in Streatham. And he's played a really important role for us in terms of offering access to the vaccination for people in Lambeth and indeed for beyond. I'm going to hand over to Ash.
Thank you, Andrew. Thank you for inviting me to be part of this. It's really important for a community pharmacy to be seen as being a component of the whole system. And we're at the heart of communities, and my own pharmacy has been a vaccination site since February last year. So we've been running for over a year. And when we started, there were 4 pharmacies. I believe there are now about 14 across Lambeth and many, many more across the whole of South East London. So we're quite an important part just of the vaccination programme. But alongside that, we've also been open throughout. We've been there to provide medicines for those at the end of life. We've been there to provide lateral flow tests. I'm sure many of you have been in to come and get tests from us. We provided deliveries at the peak during the time when people were shielding and had to have deliveries to their homes. We provided safe spaces for cases of domestic abuse or concerns through the Ask for Annie programme. And we've also been involved in some of the roving sites. That bus that you see there on the right-hand side of the screen is the Health and Wellbeing bus that, again, I've been involved with in providing vaccinations through and also providing other services, such as we've done some blood pressure monitoring, we provide mental health services through it, we do many other things alongside that. And actually the whole point is about pharmacies being seen as part of the community, being at the heart of the community, being there to be accessible and to support your care at the most important times for you, and to be able to support the rest of the health and care system in what they're able to do. So we feel that we are a really key component of what happens, but we are a cog within the whole system. And with that, I think I should hand over to someone who probably does quite a lot in that. I'm going to hand over to Kate from Bexley, who's going to talk from the voluntary sector.
Hello, thank you for having me this evening. We work within Bexley. We're an infrastructure organisation, Bexley Voluntary Services Council. We've been in a very fortunate position where we have great relationships with the voluntary sector and our partners in the NHS. We were approached by the CCG to set up and run our vaccination support programme with vaccination marshals. As we are a volunteer centre, we are well placed to be able to ensure that we have the processes to support the volunteers to run an excellent vaccination marshal programme. So we worked with PCNs, we worked with APL and North, and we worked with the GP Federation, BHNC, to make sure that everything was suitable and efficient in terms of supporting volunteers. We had an amazing amount of volunteers come forward, not only from the initial lockdown where we had over 1,000 volunteers register their support for residents in Bexley, but the number of volunteers we recruited for the vaccination programme itself was 294. We completed 1,790 sessions. They were over a 2-hour each session, generally on average. And the total number of hours given, therefore, was 8,397 hours. This was recognised by Matt Hancock, who wrote a letter to us to congratulate us on the work that we had achieved during the pandemic, and also is recognised through the borough for what we've managed to do. But it's down to the volunteers and what they gave, the time that they gave to us. We ensured that we had inducted the volunteers. We did the creation of the volunteer roles, the risk assessments, the insurance, the volunteer management, visiting all the sites, supporting the rota, and recording all the hours that they did. Just to give you a flavour of the volunteers themselves, they were absolutely amazing, but they enjoyed it themselves. So they said we were well organised. A friendly team of experienced volunteers and staff who explained everything to me, which assisted me in contributing fully. Thoroughly enjoyed it, Mrs. J. Being able to volunteer allowed me to do my part, helping those who have worked tirelessly on the front line and behind the scenes to try to make sure we're all safe. I feel honoured to be able to help, and that's from Mrs. F. And finally, I volunteered at Bursted Surgery over New Year and wanted to let you know that it was well organised and everyone was welcoming. It has restored my faith in people, and I now know why people say volunteering is like chicken soup for the soul. Mrs. S. And finally, in terms of a partner quote, which we always like to have, we like to know that our partners are happy with our service. So working with BVSE has been simple, responsive and effective. It's been collaborative experience. We had good feedback regarding processes. Volunteers have been reliable, pleasant and keen, and they get stuck in and get on with the job. It's amazing to have these volunteers helping with the vaccination programme. It's great to see what BVSE can do. It has been a real eye-opener to see what the volunteering sector can deliver. It has been a pleasure to be part of this programme. The volunteers have thoroughly enjoyed it, and we will continue to work collaboratively with our partners moving forward. Thank you very much indeed. I would now like to introduce Jo Turville, please, Director of Operations.
Thanks very much. Hi, everybody. So I'm Jo Turville. I'm Director of Operations at Guy's and St Thomas's, and I had the pleasure to oversee the vaccination centre work across many hospitals in South East London, illustrating really how the hospitals also came together in collaboration with partners during the vaccination efforts. So as you can see, the hospitals were dotted around across South East London, and we set up our mass for South East London. We set up our mass vaccination centres centred around the hospitals or run by the hospitals. So in Bromley, one of our mass vaccination centres was actually in the civic centre, not on a hospital site, but the others were on hospital sites. So you can see some examples here across King's College, Lewisham, Guy's and St Thomas's. Everybody pulling together really to deliver the huge volume that we had to suddenly deliver in not very much time. Really excellent and amazing thing to be part of, and probably one of the few things in my career that we've really pulled together across the sector to do, and across the hospital sector as well. So yeah, a great opportunity. Thank you.
Thank you, Jo. And I think it's back to me. Fantastic. Thanks to Ash and Kate and Jo. I hope that's given you a real flavour from the kind of front line of just some of the importance of working together and working closely with our residents in terms of that response. And I just wanted to give you some facts and figures now in terms of not just what we did, but what we achieved as well. So look at that, 3.9 million doses of COVID vaccine, of which nearly 1 million were boosters. As you've already heard, we've created vaccination sites in hospitals, in doctor surgeries, in football clubs, in shopping centres, and for ourselves, we did one at the Oval, in council buildings, community halls, schools, pharmacies. So the points of access that people could access their vaccine were many and varied, and hopefully met everybody's needs. Understanding data has been really critical, and this is where scale comes in. So our ability to analyze and understand what's going on, to share intelligence, to be able to collect and interpret data has been one that we've kind of pooled our activities on. We've drawn on expertise from analysts and from public health and from other places to really understand, not just in terms of what's already happened, but to start to then build that together with other local intelligence that tries to give us a feel for what's driving people's preferences and thoughts processes and so on. So how can we work with people to meet their needs? We train more than 1,000 what we call assessor vaccinators to work on across South East London. And we've been working together to kind of tackle vaccine hesitancy. So a huge amount of actual real achievements through this process. And what I hope you've really drawn from this kind of short session is that our response has been significant, but also there's been one on a whole system. So it's not been single organisations working on their own. It's been organisations and partners working together to understand what works best for our local communities. And we've asked our staff to work in all sorts of different roles and in different ways. Many of them have been redeployed. Some of them have been volunteering in different roles. Others have been volunteers drawn from the wider community. So we have tried to draw on the kind of assets that we can across the both the paid and the unpaid workforce, and that's been absolutely fantastic. And I suppose the biggest lesson for this is that obviously that's not only applicable to vaccination. We'd like to kind of sustain that into other ways of working. On this slide, you can see lots of other responses to COVID that we did together, keeping other services going, keeping people well, testing approaches, etc., etc. But we want to also take that forward into our kind of broader health and care improvement work for the whole population. So the main message is no one can do this on their own. It's really important we work together, and whether that's about integrating care at a very local level so that we can join up care around individuals, or whether it's about working collaboratively on a bigger scale to get the kind of benefits of shared learning and working at a kind of to get the best use of the workforce that we got. Both of those will be important if we're really going to challenge and make a difference to the significant health challenges that we face looking forward. So I'm going to stop there. There's one further slide where you'll see advertised a video. Now, we don't have time to show you this video today, but when we send the slides out to you tomorrow with some feedback forms, you'll be able to access that video and look at it in your own time. It only takes about 3 minutes, but it is well worth a look to kind of set out what a kind of integrated care system is aiming to achieve. So at that point, I'm going to stop. I think there'll be opportunity for some questions a bit later on. And I think I'm either handing over to Ben or to Andrew Bland. Ben, if it's you, you'll have to nod at me.
Well, I think it's me. I haven't seen Andrew Bland yet, but thank you very much, Andrew. I'm Ben Collins, and I work with Andrew Ayres, Andrew Bland and colleagues on the development of our new integrated care system. And I think it's my job with Fiona Halgago in the next few minutes to explain a little bit about the nuts and bolts of the changes to the architecture of our local system. So if we go to our first slide of this section, we have legislation that's going through Parliament at the moment that promises to create this new model of managing local health and care services called integrated care systems. That will involve various changes to the architecture of our system. In particular, we'll need to close down our clinical commissioning group and create a new thing called an integrated care board, which will be responsible for some of the big resource allocation and planning decisions in our system. I'll talk a little bit more about those architecture changes, but just to really re-emphasize the points that Andrew Ayres was making. You know, we really do see our integrated care system as shorthand for partnership working. It's going to bring together partners from across South East London, our 6 local authorities, our acute hospitals, our mental health and community services, primary care and the voluntary sector. And we're going to be now in the future collectively responsible for deciding how we can use our resources and how we can better improve care for local people. And what we really want to do, I think, in all of this is we want to develop a new, more flexible model of partnership working. So, you know, pooling the resources, the skills, the expertise and the insight that we have across our system, drawing on the skills of different partners to design better services. If we go to the next slide. So I mentioned some of, you know, the headline message is partnership. There are some technical changes that we're going to need to make to our system when we become a statutory integrated care system from the 1st of July. We'll have to create a new senior leadership board, our integrated care board. That will bring together senior leaders from across our system, and that will be responsible for deciding how to allocate resources across our system and the planning of services and overseeing the performance of our system. We'll also create at the bottom of this slide a group of very senior leaders from across our system called our Integrated Care Partnership. And they'll bring together leaders from health, local authority, a range of local public services, the voluntary sector, Health Watch, and they'll play an important role with the board in helping to set strategic direction and hold the system to account. But I guess one thing that's really striking about South East London, we are a big system. We've got some of the biggest hospitals in the world. We're serving a population of a small country, almost 2 million people. There's a real risk that as we make this change, you know, we create, you know, another rigid top-down public sector hierarchy. And we really don't want to do that. We don't want a system where all of the decisions have to wend their way up to a small group of people at the top of the system and then wend their way back down again. And we don't want a system where, you know, decisions about the shape of local services are taken, you know, at a greater distance from local communities. So we really want to empower partnerships within our system to lead change. And there are 2 key partnerships I wanted to mention. The first is our local care partnerships. So these will bring together representatives of all of the key services at the level of our 6 boroughs. And our local care partnerships for each borough will be responsible for the planning, the use of resources and the delivery of out-of-hospital community-based services. And the second partnership I wanted to mention, that Fiona will now talk about it in some more detail, is our provider collaboratives. And these will be groups, these will be partnerships bringing together all of our acute trusts in one partnership, our acute collaborative, all of our mental health trusts in our mental health collaborative, and all of our community providers in our community network. And their job will be to work together on the improvement of more specialist services. So they'll be focusing on how they can use their resources more effectively, pool skills and expertise to improve more specialist care. And as I've said, the challenge here that I know Richard Douglas feels very passionate about is how can we empower staff and partnerships across our system to feel able to go out and make improvements in care without waiting for permission from the top. And at that note, I think it's probably time, Fiona, to hand over to you to get a flavour of what the Acute Collaborative is all about.
Thank you, Ben. And good evening, everybody. I'm Fiona Howjigo. I am the Managing Director of the APC, another acronym, which is the Acute Provider Collaborative for South East London. And I'm just going to spend a few minutes trying to bring to life some of what Ben's talked about what us as a sort of a collaborative are trying to do to support our patients as part of this ICS. So put simply, we are just the 3 acute trusts across South East London. So Guy's and Thomas's, King's, Lewisham and Greenwich. We are just a way of supporting those 3 trusts to work in a new way collectively on some priority pieces of work, some things that the 3 acutes need to do really urgently, but by working together, they can achieve faster and greater results than doing the same thing separately or three times. You can see here there are lots of trusts, 3 trusts, but many sites. And again, that's part of what we're looking at, is what services are offered in which of those sites to be as streamlined and as effective with the care we provide as possible. So on the next slide, a sort of a potted history of how this came into being, because it might make more sense when I bring it to life. During the first wave of COVID, the 3 trusts were sort of sitting in glorious isolation across South East London and collaborating to a degree, but not in a formal way. But they had to start working together in new ways because of COVID and because of the need to share people or our patients through critical care and for other urgent reasons. And they discovered actually they worked together quite well and it was quite effective. So agreed that there are some areas where they really could work together more formally. And so they decided to focus on recovering our elective and our diagnostic position. Effectively, those patients, we had too many patients waiting too long across all 3 trusts. And we thought actually by pooling and working together, we could probably do better than working separately. The second COVID wave made us work even closer together. And then national guidance came and said everyone needs to be in a provider collaborative. Luckily, we were ahead of the game. We were already starting to do it, and we're trying to formalise it. We're not a separate organisation. We're not another organisation across South East London. We are simply knitting together some elements of the 3 acute trusts. So the length on the next slide, I've drawn sort of a really simplified surgical pathway. This is very simple and not a path that all of our patients will follow, but it sort of suggests that you go to your GP for your initial for an initial appointment, and then you follow a long and winding path, and eventually you will be discharged after various tests and perhaps some surgery. And there are elements along this pathway where there is commonality across the 3 trusts and where we can do something collectively to make things faster. So we've put some examples here, but there are many more things that sit behind it. But there's some access for your GP. When you go to your GP, they might want some specialist help to give you some better advice about how you could be treated. And to save you going all the way for an outpatient appointment, you could get some advice and guidance there and then, or your GP could follow up and get back to you. That's something that we can do collectively, simply 3 times, once instead of 3 times. Another example is sort of doing some validation work, which is us looking at lists, but making sure when you're coming in for an appointment, you are seeing the right person in the right place at the right time. And so sort of going through the list and being really careful and sensible about how we can streamline our patients. And then the third one I'll draw your attention to here is thinking about, have we got enough operating theatres across the 3 trusts and how can we share them better? And on to the next slide. There's a real live example of what we've done. So we've got 2 brand new theatres over at Queen Mary's Hospital in Sidcup, which have been built for the use of all 3 trusts. And it's the first time that 3 trusts have started working together, sharing surgical facilities like this. We use them for gynecology and general surgery patients, and patients have loved the speed of access to these theatres and the shiny new wonderful facilities, and they're happy to go and use them. And similarly, our surgeons and our theatre staff love operating them because they are so new and they can work so effectively. So that's a real tangible example of how working together we're improving things for our patients. And then finally, the second example, is again getting more access for our patients early on in their path through the acute setting, and that's getting them better access to diagnostic facilities. So we've bid successfully to get a lot of capital into South East London to get early access to funding for more scans, MRIs, ultrasounds. So we've done about 3,500 extra scans across the system, where patients from all over South East London can go to these facilities and get scanned faster and more effectively than they were before. And again, we're working on weekends because that suits our patients better. And again, we've had really, really good feedback from them. So hopefully that sort of brought to life a little bit about what the collaborative is, but more importantly, the tangible stuff we're doing for our patients to try and get them a better and faster journey through the acute and back home and discharged from hospital. So I will hand over back to Ben.
Thank you so much, Fiona. So what I thought I'd do now is just talk a little bit about the thinking that we did last year on the priorities, the things that our system as a whole should really focus intently on. Before I do that, can I just remind everyone we're coming up to a question and answer session. If you have questions that you would like us to answer, please do put them in the chat. And if you put them in now, as opposed to just before the Q&A, I think you'll get a better response from us because we'll have had a chance to think about them. So please do put your Q&A in the chat and we will come to as many questions as we can. So as well as this thinking on governance and architecture, and as well as establishing these new collaboratives, these new partnerships within our system at the level of our boroughs and our providers, we've also been thinking about, the really big priorities that our system needs to focus on over the next few years. In the middle of that last year, we honed in on 6 major cross-cutting priorities for how we deliver care and how we improve the lives of people in South East London. Now, if we go to the next slide. Now, the first 4 of these priorities, I think, are relatively well established, because the truth of the matter is that we've known for a very long time now that we need to complete this shift from a system that treats people when they get sick to a system that becomes much, much better at supporting people to stay healthy and to enjoy happy lives and well-being and avoid illness in the first place. Likewise, we've known for a very long time that we need to address the complexity and the fragmentation that has built up for a long time in our local services and in other local services, and we need to develop models of care that deliver more whole person, holistic care in the community and close to people's homes. And by that I mean care that addresses all of our needs in a joined up way, our physical health, our mental health, our health needs and our social needs through joined up teams. We know that we need to ensure that we can deliver access to high quality services quickly when people need them. We're really fortunate in South East London in so much that we have access to really some of the most outstanding specialist services in the world, but we do need to improve people's access to them, and we need to ensure that there's consistency in terms of the quality that we offer across South East London. And then finally, in terms of these things that we've known for a long time, we know that we need to do better at joining up our system so that we make better use of staff and resources and better coordinate care across different chunks of our system: primary care, community services, social care, and the hospital system. And for me as a dad and as a son of very elderly parents, this is the thing that always strikes me. So before Christmas, my daughter had COVID. She was having breathing problems, and we bounced from, small services from primary care to community clinics before we ended up in a paediatric A&E. And I think that didn't happen in South East London, but it could have done. It's the sort of problem that we see across healthcare in England. My elderly mother is in hospital. There was seemingly, she's delighted with the care that she receives in a wonderful NHS hospital outside London, but social care and healthcare really struggle to join things up for an elderly lady in hospital and an elderly husband left at home. So these are things that we've known for a long time. I think the challenge is to develop more effective methods of progressing some of these priorities. And as I've said, we're all about, in the future, collaboration, partnership working, and harnessing our collective resources to address these big challenges. The last 2 priorities on the list are newer, but they very much reflect the shape of South East London coming out of the pandemic. We all know that post-pandemic, South East London's facing very significant socioeconomic challenges, very high deprivation, very significant social inequality. And that's translating into illness, disability, and huge lost years of life, a 10-year gap between the richest and the poorest in South East London. So we need to focus more intently on how we address health inequalities, by which I mean how we address unfair differences in levels of health and access to healthcare between social groups. And secondly, we need to start using our economic power more effectively to support our communities. So we know that the underlying driver of poor health is inequality and deprivation, lack of access to power and resources in the world. We spend 10% of the nation's GDP through the health and care system. So there is a lot of leverage that we could apply to address those social and economic challenges if we want to. And we want to become much more effective as community anchors, doing things like hiring our staff, helping people from deprived groups to progress through the health and care system and have high quality careers, purchasing in ways that support the social and economic development of our communities in South East London, and using our buildings and our investment in ways that support local people. So I will just move now to, dare I say, a slightly drier slide. I wanted to mention our constitution. So one of the things that we need to do as we close our CCG and create a new integrated care board is to establish a constitution. We have a draft constitution that we've shared with you. As I've said, this is all about close partnership working and making collective decisions. So the constitution the constitution will put in writing our commitments to joint working across our system, drawing on leaders from across our system to make the big decisions. The constitution
Hello, I think Ben's internet has gone down, unless it was mine. I don't know if anyone else can just help clarify.
I think Ben's frozen.
Okay, I don't know if oh, Ben, are you back now? Oh, Ben is leaving, I think, in order to try and get back in. Our apologies, everyone. I think there's less bandwidth in the evening as everyone is back from school and goes on to their internet. Bear with us for a couple of moments. Ben, are you back? Marvin.
I am back. I left you in mid-sentence on the most exciting points about the Constitution. Do I have time to finish them briefly, Rosemary?
You do, yes.
So very briefly, everyone, the Constitution covers things like, well, it sets out our collective leadership and governance arrangements for our system, with leaders from across our system responsible for making decisions on how we allocate resources and plan services. It sets out eligibility criteria and appointments processes for our board's members, principles of good governance, information on our committees and subcommittees, and procedures for making decisions. It's not the most scintillating document, and most of it has been prescribed for us by the national NHS. But if you do have questions and comments on it, we'd welcome them in the next week or so, if that's possible, because I think we need to complete this process by the middle of March. And at that point, Rosemary, am I right that we have a 5-minute break before our Q&A session?
You're absolutely right, Ben. We're about 5 minutes ahead of time on the agenda. So if I can ask people to take their break now and come back for 6:50, and Jonty will facilitate the question and answer session. So thank you, everyone, and do come back for 6:50 rather than 6:55 as it says on the screen. Thank you.
welcome back everyone after what was a pretty short break, but hopefully you've been able to rejoin us. Just by way of introduction, well, the first thing I should say, apologies if there's some background noise. I'm doing my own tour of South East London at the moment, so I'm coming to you live from the South Bank, but it's wonderful to see so many people. I'm John T, I'm a GP in South East London. And I have the great privilege of chairing this CCG, and I've been involved in our thinking around the ICS. And I'm just going to try to draw together some questions that we've received both before and during this engagement event. I would say that we're not necessarily going to be able to get to absolutely every question, but what we will ensure that we do is to capture all of the questions that have been asked, and we'll be sharing fuller responses following this session. But once again, thank you so much for joining us. So one of the questions that has been coming up, so this I think is really important, and it's around the way in which social services are involved. I'm going to come in just one second to Andrew Ayres to talk about this. I mean, it may be that in the talks so far we haven't adequately, I guess, emphasised the particular opportunity there is around partnership with social services. I think, Andrew, I wondered whether it's worth talking a little bit. We had some questions before the meeting around the broader benefits and improvements the ICS will bring to individual patients. And I wonder whether you might want to talk a bit about that, but with a particular emphasis on the opportunity for integration with social services. Can I pass to you to answer that question?
Yeah, thank you, John T. It's a very good question. So what the most common thing that people talk to us about in terms of their experience of care is how complex it can be, and how they often feel that they're left to navigate it themselves and to kind of coordinate their own care across the various agencies and often across the NHS and local government. And that can bring with it different rules and different arrangements and so on and so forth. And at the same time, professionals tell us that they can find it frustrating. There are things that are outside of their control because they sit in a different organization or a different set of rules or a different process. So absolutely what we're trying to do through integrating care, particularly at a local level, is to bring those professionals together, to bring those organizations together, so that from the perspective of the resident who's seeking support and care, there's a kind of seamless and kind of clear route for them that they can be supported through, as opposed to them having to navigate for themselves and work their way through their kind of complexity, is the kind of example Ben gave earlier. And social care is a really, really important part of that, because many of the entry points into the health and social care system sit in social care, either at the excuse me, the kind of more universal end, where people just need kind of low level support, but that might lead them to other types of offers that might be available from the third sector, or for those who are more vulnerable, into kind of more advanced and complex means of support, which often requires drawing on many agencies. And so social care is right at the centre of what we try to do in our place-based partnerships. And if you look at my title, so my title is Strategic Director for Integrated Health and Care, and I have responsibilities both in the NHS and in local government, including for adult social care and for some children's services and for public health. And all of those kind of professions and teams and resources play a part in people's integrated care. And just one example I would give, so in our mental health services in Lambeth, we create what we call the Lambeth Living Well Alliance, which brings together not just mental health services from the NHS through South London and the Maudsley, but also adult social care, increasingly general practice, but also beyond that into housing and employment providers as well. So that we're seeing people not just from the perspective of their medical condition or their specific health needs, but trying to put that in the context of their wider lives and the things that will keep them well and keep them resilient and hopefully keep them out of crisis. So absolutely, the whole approach we're taking is one about meeting people's needs whatever they're presenting, and they won't always be medical needs. They'll often be social care needs or other needs as well. And the more we can build that support around them, but the more we can keep them well for longer. So social care, absolutely critical part of what we do. And even in the COVID response, they've been absolutely central to both supporting hospitals, but also kind of supporting people in their own homes, whether that's in a kind of care home or residential home setting, or through domiciliary care as well. And all of that is kind of integrated into a kind of shared planning approach. So yes, fundamentally important part of what we do.
Thanks, Andrew. Really, really helpful. And of course, we focused a lot at the beginning of the evening on the vaccination programme. We could easily have talked about things like the response to shielded patients, which absolutely involved a combination of partners in a very similar way, and very deeply involved social care as well. So thank you for that, Andrew. Apologies again for the background noise. I'm going to move rapidly on to another question. So Tony, I should say, I hope that does answer your question. We've had questions from both Colenso and Jane around who South East London ICS is accountable to, and how patients and the public will be represented through the ICS board. I wanted to ask Anu, seeing whether she would come in and just say a few words about this, but also I may come to you, Ben, to contribute to this answer. So Anu first, yeah.
Thanks, John T. Thanks, Jane. Great question. And actually, it's a question that we've been really worrying about over the last 8 or so months. So a little bit of context. We have a lot of drivers, a lot of reasons why we want to make the ICS really truly accountable. One of them is the actual NHS constitution itself, which outlines the fact that we are, as the NHS, absolutely accountable to the public. And then, of course, all of our partners have different obligations about accountability. So really strong local democratic roots across local government partners, and all of our partner organisations have signed up to a commitment to being truly, genuinely accountable. So we've looked at really creative ways of doing this, and we've been testing some of these ideas with communities and partners over the last few months, and we'll talk a little bit more about that later on. But just very quickly, there are lots of ways. There's being open about decision-making processes, there's involving people in decision-making, there's scrutiny on our decision-making, and there's making sure that we use a variety of different conversational methods, not just the bog standard that perhaps people are used to seeing, but that we're really creative about engaging all of our populations and making sure that both our decision-making and also what we're interested in doing in the kind of months and years to come is really co-produced by the communities we're here to serve. So more on that later.
Thanks, Anu. We're hugely thankful for the work you have done to lead this, along with Rosemary and the team. And Ben, you've been involved in this and obviously been thinking about it from a governance perspective as well. Did you want to add to that?
Only as a sidekick to Anu and Rosemary, Jonty, but it's probably worth adding that we'll also ensure that the voice of patients and the public is heard clearly in our most senior leadership group. So we'll have Health Watch represented on our partnership, and we will of course have non-executive directors to help us bring the voice of patients and public to the fore in our board. Beyond that, it'd be out of place, I think, for me to talk too much about this because Anu's the expert and we'll come to it. I'm hugely excited about how we can become better at engaging the voices of groups of people who have historically been overlooked or not given the voice that they deserved in health and care services. So how can we involve people with learning difficulties, people with mental health problems, people, young people, single mothers? There are many groups that I think we need to go out and actively recruit. And as Anu's been thinking about, that means proper resourcing and proper support for those people to participate in our system.
Thanks, Ben. One of the other questions that actually came up prior to the meeting, but I think Katie has raised again, is around how the ICS works with private sector companies. And I wanted to bring Richard in. I'm hoping Richard's internet is still there. Richard, I'm wondering whether you might just help us with an answer to Katie about how we work with private sector companies.
Okay, I am here, John T. Don't worry, you've not lost me at all. So I can start off on that and be absolutely clear to people from the start. The partnership is a partnership of public sector, statutory organisations and the voluntary sector. So nobody on our governance structure comes from the for-profit sector. And I think there's been a bit of mythology around that. So I'm absolutely clear there is no for-profit representation on our governance structures. Now, that doesn't mean we won't use the for-profit sector in some way in delivering health and care. We always have, and they provide a valuable role for us. But I need to be absolutely clear, this is a partnership of public sector, statutory bodies, voluntary and community organisations, not sort of directly engaged in the private sector in our governance. And if I could, while I've got the floor for a minute, John, to just add on the accountability issue, because I think this is really, really important. Nothing in what we're doing here in terms of our governance removes any element of accountability. It actually adds accountability in a way that we've never had before in the NHS. So we will have, and Anna will discuss the sort of public and patient involvement and engagement. But yeah, historically, the NHS and the work that people like me have done have been entirely accountable directly to central government. That accountability to central government will continue because money flows from there. But what we're creating here as well is something that is accountable to South East London. So our partnership that will oversee the work we do will include political leaders from across all the boroughs in South East London. And as well as that direct accountability to central government, we will be accountable to that partnership. Now, that has never, ever happened before. So this is adding accountability. Nothing will be removed in what we do in terms of local government scrutiny of what we do. Nothing will be moved in terms of institutional accountability through governors or public and patient involvement in hospitals. I think it's really important to stress this adds a layer of accountability that we've not seen before.
Thanks so much, Richard. Really, really, really helpful and really clear. I'm delighted that Andrew Bland, I very much hope, has joined us. Wonderful, Andrew. It's so good to see you. I know that Ben covered for you earlier brilliantly, but it's so great that you've been able to join us. You may want to introduce yourself, but I wondered whether you could also first answer a question that's come from Jane around. So there's a couple here. One is around kind of how decisions be made about where NHS funding goes to make changes and meet our priorities. Very much linked to that, Jane has asked how far we'll go to actually change those priorities and those resources. Would you be happy to pick that up and perhaps just introduce yourself? Thanks.
Yes, so apologies for being late. I can't actually see myself, which I'm sort of seeing as a bit of a godsend, but apologies to you guys anyway. And I'm the Chief Executive Designate of the Integrated Care Boards and therefore of the Integrated Care System. So and I know a number of people I can see on the list of attendees. So thank you for that. And good to see so many of you. So I think, John, if the question, would you mind just give me the first question again? Apologies.
No, not at all. Of course. So there's a question. It's really about how we're going to use funding to make the changes and meet our priorities. And I think to clarify that, Jane has asked how far we'll actually go to change the priorities and the way we allocate resources going forward.
Yeah. So thanks so much, John. I mean, so the first thing to say, and I expect Ben may have covered it earlier, is that we will be a board of partners that aren't operating in an internal market with transactions between one party and provision from another. So I think first and foremost, we will have a single allocation of funds available to us and a set of principles against which we seek to deploy them. In that sense, we have a change straight away in that we are involving our partners and providers directly in decisions about how money is spent. I think we have a determination to be a population orientated system. So I think gone will the days be of contracts that are focused upon activity and how much we can squeeze activity out of each of our providers in silos. Instead, I think we're going to look at population need and try to give our funding on a delegated basis. Again, something I imagine Ben has picked up, delegated to a group of partners, providers and planners of health and care services to decide how to best use that money amongst them. So a single pot that we're determined to drive best value from. So two changes straight away. In terms of the delegation of resources, we're also looking for solutions beyond the health service. So I'm very much hoping that we're going to set an ambition to spend money a bit differently in a couple of hopefully predictable ways. One is that we will seek to ring fence and seek a return on investment on monies on upstream or preventative actions or those things that keep people well, and recognise that to do that we might have to fund some different people that we're used to. Certainly I'm used to in the CCG. So in the third sector, community groups, those people that might make a contribution where the return on investment might be over a longer time period, but it's certainly there. So some of the differences that we will seek to put forward. How far are we willing to go? Well, firstly, we will operate in a financially constrained environment, and for me to duck that would be silly. So absolutely, we will be looking to make sure we live within our means. It's a long-winded way of saying as an organisation. That said, I think we are determined to make a difference, and we see delegation and decision making amongst our board members as to where we deploy our resources to be driven by population health need and analysis. So that I think will be what we seek to do. However, we also operate within an NHS national framework, and that national framework is helpfully, from my point of view, guarantees growth at a higher rate for primary care services, for mental health services and for community services than the rest of the health service. And from my point of view, that sort of national steer and requirement is a helpful thing for an organisation that's trying to invest in the out of hospital sector to make sure that we keep people as well as possible. Final thing to say, we are creating an opportunity, not providing a guarantee. So the opportunity is we'd very much like to take financial decisions about the overall public sector purse available to health and care. So Andrew Ayres has talked about his title. It's instructive from my point of view. Andrew and Lambeth will be able to make decisions about health service spend and money, but also some of the resources available to the local authority there. We'd like to replicate that in each borough. So joined up decision making, I think, may lead to quite a different way of spending money. Thanks, Jonty.
Thanks, Andrew. That's a really full response to Jane's question. Just before you go, there is one other question that Jane's also asked, which is about the workforce and how these changes will help us address some of the workforce issues, which I think are so stark at the moment across health and social care. Do you have any thoughts on that?
I do have thoughts on that, John. I mean, the first thought is I don't want to use this answer to sort of in some way pretend that this is anything other than a huge challenge and one that we're not going to resolve just by changing the sort of template or the letterhead on our organisation. So I just sort of say that up front. We've got a huge challenge here, both in terms of morale, the amount of workforce we have, how we've trained them in the past or over the last decade or two, and now the inheritance of that. So we've got an absolute fundamental issue, and of course our people are our biggest and best assets. So just a few thoughts on that. I mean, the very literal thought is we're going to use a people board that draws the talents from across our system together to consider workforce issues, rather than people have, like myself, historically plan in one room and then speak to employers and people in another. So we will do it in a joined up way around a people board. We are going to be interested, I think, in three things particularly, John T. First is how we attract and keep people. And that's going to, in large part, be about treating them well. So we will have an absolute relentless focus on how we look after our staff. We also need to redefine our staff. So in my mind, the ICS is looking to make a difference for over 100,000 people who work in South East London, but that's NHS, local authorities in many regards, the third sector, our care homes, and I could go on. So we're going to broaden our definition of the workforce and not look at it in silos. Certainly I've traditionally looked at the health service. So attracting and keeping people also rely on us being able to collaborate really, really well. So it may be that someone is attracted to work in Guy's and St Thomas's as a major teaching hospital, one of the biggest that this country has to offer. But they might, in doing that training, be exposed to and have rotation through some of our smaller trusts out into the community as a shared provider at Guy's, or into general practice or other areas. So I'm hoping that will assist us as one form of collaboration. I should also say I'd be pretty remiss of me, and I don't know if Ben has picked this up, so apologies, but we want a focus that allows us to stand a better chance of attracting and employing local people. So can we create employment opportunities in different roles? I've been really taken by the number of social prescribers we have employed for our PCNs in South East London, if anybody has come across them. Entirely different types of roles that we've been able to work with local people to attract in, with all sorts of benefits that being employed comes with for your mental health, self-esteem, all of those things that will add to people's health and well-being. And the final one, John T, is just a clear commitment from me, our future board and our people board, that we recognise that our equality, diversity and inclusion approach is absolutely pivotal, not just because we believe in it, but all the evidence shows us that if we do have a workforce that feels treated well, included, is diverse and reflects the population we serve, then it tends to do better for that population, and that population tends to trust it more. And I think from my point of view, there are a few of my thoughts around workforce, John T. Back where we started, our biggest challenge.
Thank you, Andrew. Again, really full answer. So I'm aware that we have taken up our time, I think, on the question and answer session for now, wanting to ensure that we kind of keep the time as much as possible. We've still got some important speakers to hear from, and I'm going to leave the conversation in a moment. Ben is kindly going to take the final question and answer session a little later. So please, if you have further questions that we haven't responded to yet, do put them into the chat. We will either try to answer them in the chat or we will be able to answer them in that final session. And as I say, if there's anything we don't get to, we will ensure that that we share a fuller answer to all of the questions following the meeting. So can I once again thank you very much for contributing such interesting questions. I'm going to hand over to Catherine Mbema now, who is going to talk to us about the people's well-being in South East London, which Andrew has rightly said is going to drive so much of the work that we want to do as an integrated care system. Lovely to see you, Catherine. Over to you.
Thank you so much, John T, and it's good to see so many of you on the call this evening. So I'm Catherine Mbema, Director of Public Health for Lewisham, and I'm going to talk to you for a few slides around the types of things that affect the health and well-being of South East London residents. So if we can move on to the next slide, please. So the first few slides I'm going to present look at the causes of death, or the main causes of death in 2 South East London boroughs. And to give a bit of contrast, we'll look at Bromley and we'll look at Lewisham as well. So the first slide here, you can see the top causes of death for Bromley residents. You can see the Bromley population there is 330,000 population. And this data has been taken from the Global Burden of Disease study from 2019. And if you look at maybe the top 3 causes of death, you can see the top cause of death there is neoplasms, otherwise known as cancer, followed by cardiovascular disease. So that's heart disease, heart attacks, heart failure, so on and so forth. And then followed by neurological disorders, which encompass a whole range of illnesses, including things like epilepsy, Alzheimer's disease, strokes, so on and so forth. And then you come on to respiratory disorders, chronic respiratory disease, and another category. And though we know that the cause of death aren't the only things that affect the health and well-being of our populations in South East London, of course there are things that make you, very seriously unwell that don't lead to unfortunate death. But we've started by looking at causes of death just to give you an overview of some of the headlines and some of the most pertinent or biggest health concerns for South East London residents. If we can move on to the next slide, please. So then moving on to looking at the causes of death in Lewisham. And so you see some similarities, though Lewisham and Bromley have quite different populations, different demographics, different causes or influences around health. The causes of death are really quite similar across the two boroughs. So I'm looking at this table here and looking at the population of Lewisham, very similar in size, so 305,000 people in the population there. Again, the top cause of death for Lewisham residents is, again, cancer, followed by cardiovascular disease, as we saw for Bromley. So that's heart attacks, so on and so forth. And then chronic respiratory illness, for example, chronic obstructive pulmonary disorder, COPD, and then infections, and then you do have other categories there. This data has been taken from a slightly different data set, so it's from our primary care mortality database. Those shows a very similar picture, with cancer, cardiovascular disease being our top cause of death across Lewisham and Bromley, and will be reflected in other South East London boroughs as well. So we've looked at sort of the more severe end of things in terms of health outcomes. As I mentioned, there'll be a whole range of things that impact on health and well-being that don't cause unfortunate death. But then if we look further upstream at what some of the causes of ill health and unfortunate death are, some of these conditions that cause unfortunate death, I think it's really important for us to look at those influences, some of those drivers of ill health, because as an integrated care system, or ICS, we don't just want to treat ill health when it occurs, but we want to try and work on prevention, early intervention, hopefully preventing people from coming into contact with health and care services. So if I can move on to the next slide, please. So if we look at some of those key drivers, some of those key contributors of health, the Health Foundation have done lots of work on this to really simplify some of the evidence that we have of things that cause ill health. And you can see the infographic here on the left-hand side of this slide, looking at the things that make us healthy, so the things that drive our health. And they include things like the jobs that we have, so do South East London residents have access to good work? What are our surroundings like? So do we have access to green spaces, etc.? Money and resources being a big driver of an influencer of health. Housing, what types of housing do South East London residents have access to, and what is the quality of that housing? You have, sorry, my eyesight there, education and skills. So educational opportunities. What other levels of educational attainment? Again, those all influence health and drive health. The food we eat, so access to a healthy diet. What does that look like for South East London residents? Access to transportation, again, that's linked to employment, linked to work. How accessible are our boroughs, and what are the transport links like? And then finally, social connections, so our friends, family, community. Some of you have asked questions about the role of community earlier on in the session today. All of these are really important drivers of health. So they're the things that are upstream, that though as an ICS we're looking at health and care, can we also lead, interact with parts of our system that have influences on work, things like housing, money and resources. Just looking at the drivers of health, looking at some of the more severe end of health, just to give us a flavour and a picture of some of the key issues in South East London, and trying to make those links and connections with the aspirations of an ICS to both look at the drivers, causes of ill health, but also the treatment as well. If I can move on to the next slide, please. So after giving a bit of that brief snapshot, we want to hear from you about your health and well-being, what kinds of things affect your health and well-being from your day-to-day life, and what kinds of things make it difficult for you to look after your health and well-being. So I'm not sure if we will be able to get the do poll link into the chat. I hope so. I'm just going to have a quick look. But if we don't, we may well circulate these questions after the session for you to feed back to us. I know we do have the do poll there, so I'd ask you to click on that link and to please respond to those questions around things that affect your day-to-day, things in your day-to-day life that affect your health and wellness, and also things that you might find make it challenging to look after your health and well-being as well. And then we'll collate those, have a look at those. I think it'll be really important to get that feedback to support our planning as part of our integrated care system. And just a note there that you might need to copy and paste the link into your browser to get to that do poll. So we may well start to see some of those responses onto the screen. If not, I'll wait to hear back. We may then move on to the next speaker.
Thanks, Catherine. We're endeavouring to share the screen of the results so you'll be able to reflect on what people have said.
Great. Brilliant. Okay, so no responses so far, but please do send those through. Okay, so we're starting to see some of those come up. So challenges with work, balancing work and healthy living, a challenge for many of us, I would say. Work stress, physical activity, again, is important, but again, diet, challenges with diet there. Also pollution and lack of opportunities for exercise, so linking into our surroundings part of the drives of health. Again, finding time for leisure or exercise and work-related stress. Again, air quality coming up there, linked to pollution. And I'll see if we get a few more response on this one, and then on to what things make it difficult to look after your health and well-being. So we have some healthcare type responses coming through around accessing GPs, accessing primary care. Again, that balance between finding time to exercise and also balancing that with work life and family life as well. Traffic we've got there. And I think further responses around workload and not only impacts on finding time for physical activity, but also to maintain a healthy diet. And challenges with tiredness there, stress. So I think we've seen a family caring responsibility. So that slide that I showed about the drivers of health, many of these are things that you're that are coming up through the do poll. So work-life balance, our surroundings, the type of foods that we eat, physical activity and healthcare. So it didn't appear on that infographic, but health and care, which is what we're working together on in this ICS, also does have an influence on our health. Not the biggest contributor, but an important one as well. And then we can see more coming up there around traffic and access to information when you need it. So communication with services. So all of these responses are really, really helpful. I think we're going to take some of these back and to collate them into the findings or the sum up of this particular session.
Thank you, Catherine. And that's a really great point to hand over to our next speaker. So if we can put the slides up again, and it's over to Anu Singh, who will talk about how we work with people and communities. Thank you, Catherine. Thanks, Anu.
Thanks, Catherine. What a great point for my slot to come in. So I'm glad we've trailed this a little bit as well, because both in the chat and the conversations, there's a real sense that people are really keen for us as a system. Again, going back to once in a lifetime, this is an opportunity to do something different, for us to really work in partnership with our communities. So happily, that was the starter for us when we were thinking about how do we build this new way of working. We were really ambitious. We wanted to go far and beyond any practices or ambitions or cultures that we'd had previously, and building on across best practice across our 6 boroughs. So again, a real opportunity for us to build something really powerful. And one of the key drivers for us was that recognition that it's actually only by working in partnership with our communities that we can really improve outcomes and close those unfair gaps. So all of our partners across the voluntary and community sector, across the NHS providers and commissioners at local authorities, wanted to be really ambitious around the duties that we've isolated here. So a duty to be truly accountable, our duty to really take co-production seriously, and our duty to really learn from our communities. So thanks for putting the slide up. So the background to some of this is we've been working with a range of different service groups, a range of different voices to really understand what good looks like in this space. And so the first one, oh, just back a slide, thank you. Thank you. So a little bit of context here. What we wanted is we wanted to do something that truly made a difference. Now, there are a number of drivers that helped us think through some of this. So we've had some guidance coming out from the national team, and we've also got best practice. So what we've done is we spent some time working around the 6 boroughs, really trying to understand what good looks like. So we put together a steering group of practitioners, individuals, service users, community representatives to really understand what good looks like. We've also taken a number of versions of our ideas to various groups across the 6 boroughs. So one of those groups is a group that's attached to the CCG, which is an engagement assurance group, but also patient groups, and then worked very specifically with some partners who have tried to help us hear from those communities that we are not good at hearing from prior to some of these things that we're putting in place now. So the first one on this slide, we've explored how we can become more easily accountable to people. So we've already talked a little bit about this. The context here is we've got a lot of information. We have a lot of decision-making power. We also spend a lot of money. So how can we make sure that all of those decisions, all of those inputs are really opened up to the people that we are accountable to? So we've come up with some ideas around how we can do more around being transparent. So publishing more of our information, how we can help people understand our information. So absolutely working with people within the community to broker some of the decision making in a way that makes it more understandable to the groups who want to hear more about, and also having a different way of communicating. So we've got some digital platforms, we've got some venues that we're now exploring better use of, and also looking at publishing information very differently and working very differently with our elected members. Next bit on the slide is having people with lived experience as part of our decision-making process. Sorry, just flick back a slide, thank you. So of our decision-making structures. So we've already talked, all the speakers today, about a range of different programs, activities, investments that we're making. All of those have their own discrete program boards or people that are managing or running those. And we've made the decision to really make enormous efforts to bring people with lived experience, community representatives, into part of those decision-making structures and those program boards. The third one around co-production, we've been quite humble, I think, in that we have realised that we don't really do co-production that well. We might think we do, but actually sometimes that's just engagement. So again, how can we co-produce everything we're doing, and especially the most important directional change pieces, really co-produce those with the people that matter. And then the fourth bullet point here, again, we've talked a fair bit about this, but really this underlines everything that we're doing. The reason why we want to work very differently with people in communities is that we know without that engagement, we will not be able to address the unfair differences in health and make a difference to closing some of those gaps in health inequalities. So if you wouldn't mind just going to the next slide. One of the things that we've learnt is that we felt that we hadn't had a clear vision and a sense of actually what good looks like in this space. So again, we've spent some time working with stakeholders to really tease through what a vision could look like for this programme of work or this approach. So working with local people to build a healthier future for all communities across South East London. And then linked to that mission, linked to that vision, a mission around our integrated care system, working in partnership with local people and communities. So improving the health and well-being and supporting people to thrive and live healthier lives. Prioritising working in partnership to address health inequalities, which are the unfair differences in health between different groups of people. And the reason why we felt it was important to have a vision and a strong mission is that we're not in this by ourselves as one ICS. Actually, we are the component of all of our partners across South East London. So all the organisations that form part of the ICS will have their own culture, their own processes of working with people and communities. And actually what we need to do as a system is we need to harness that expertise, to amplify it, and to build those conversations into some meaningful change where we can add that value. So I'm going to pause there, and I know we've got some time for some questions a little bit later on.
Super, thank you so much, Anu. And I think we are straight on to our last few minutes of questions before we'll turn to Richard Douglas to wrap up the session. But Anu, before you leave us, I was wondering, there was a question that came in about how we can work really effectively with unpaid carers, and it struck me that that's an area that's close to your heart in relation to people-powered health and harnessing the power of our communities.
Absolutely. So we talked a little bit earlier on about the kind of groups of people that we know we aren't working effectively enough with, and unpaid carers slap bang central to what we want to do differently. I already mentioned programme boards. There's a specific way where we want to get better at hearing voice. So we know that actually you need to pay people for their time. You need to be where people are. You need to make it easy for people such as carers who are incredibly busy to engage with us. And then we need to demonstrate that we've been listening and have made changes based on what we've heard. So that could be changes to policy. It could be targeting investment differently. It could be working very differently across everything we do, especially because carers do feature so strongly in everything that we do. So that's a really good example, Ben, around how we as an ICS probably need to have different systems and structures about how we develop what we're doing and better bring in unpaid carers into that decision making and that policy development, as well as the accountability, which, as Richard said earlier, is a avenue that's increasingly kind of opening up for us and is kind of new territory we haven't been to before.
Anu, if I can pick your brains on one other point that's come up. Now, it strikes me we've got some pretty big challenges in our system. You know, we are, as Andrew Bland said, going to face financial difficulties. The needs of our populations have increased very significantly during the pandemic, and it strikes me we're going to need quite radical innovation in some of our services to deliver what people are asking for with the resources that we have available. And it strikes me that patients and the public are such a valuable source of inspiration in terms of innovative thinking on services. Anu, can you give us your thoughts on how we might bring patients and the public more actively and effectively into the work that we do on service change?
Thanks, Ben. So, you used an amazing phrase there, people-powered health. That's exactly what it's about. And the insights that our people can give us are invaluable, because actually the people that we are here to serve are the ones that are working their way through the pathways that are overly complicated, or the handovers that are disjointed, or the information that isn't clear enough, or the over-medicalisation, or whatever it is that people might be experiencing. So it's only by really working and understanding how people experience health interventions or care care interventions, that we can actually do any of the transformation that we need to. So again, thinking about how we approach some of this differently, we have to put clinical staff in rooms with patients, with communities, with carers, to actually do some of that co-production very differently. And what makes this different from how we've approached things in the past is we're really keen to resource it properly. So it's about finding the right time to build people-powered change rather than perhaps service-led change. It's finding the resource to make sure that we get the right people in the room. So, you know, we've heard from people that, you know, they can't even, you know, that the bus fares are too expensive, or, you know, the times are wrong for them. So treating our people and communities in the same way that we treat paid clinical staff, respecting their time, being able to make sure that they are in the room making the changes in the way that our managers and our clinicians are too.
Super. Thank you very much, Anu. Can I bring Andrew Bland in? Andrew, there are a couple of questions, and there's a difficult one that's come in from Gay Lee, or Lee Gay, and he asks, I don't understand how this vision and mission are different from what South East London has been doing for several years. How do we respond to that challenge, the fact that we've been working on these priorities for some time?
Thank you, Ben. I know Gay, and it seems that you're newer than me. So hello, Gay. Thanks for your question. There's a bit of me that wants to say I'm not too concerned that you're not noticing a huge difference, because we have got a change in the law nationally, and we have got a set of timetables that the Secretary of State will set out. But from my point of view, we have been trying to work as a health and social care system to improve people's outcomes on a population basis for some time. So I'm not hugely apologetic if there seems like there's some consistency there. Indeed, in the last 2-3 years, we have been reshaping our commissioning infrastructure, admittedly in the context of an internal market, to try and make sure we are more population focused. Andrew Ayres happens to be on the call from Lambeth. We appointed Andrew to his position, hopefully with his absolute consent, 2-3 years ago. So we are on a journey seeking here. So in some ways, I'm glad. In other ways, I'm concerned because I think we have been saying we're doing it, I think, more correctly. We have been planning to make improvements, and we're now faced with quite a difficult and worsening position for South East Londoners, particularly in terms of inequalities. And I guess a lot of this agenda we're pursuing is a rethink or look or test, and I think public health colleagues would back me up here, on how much the health service can do on its own, or how much any one institution within our health service family can do on its own to really make a difference. And I'm absolutely of the view and conviction that the NHS does wonderful things, usually when you're sick, and that's the most expensive and unaffordable way to look after people. And it's not the way in which they would like to be interacted with, to have independence and well-being. And so I think that requires us to bring in a more meaningful way the third sector, our social care colleagues, but the wider council as well. And I've been involved in this system for over a decade, some colleagues on the call even longer than that. And bluntly, I don't think we have been as focused on that as we should have been. So this opportunity to have an integrated care partnership with our local government colleagues is a step on the opportunity to not have a transaction between people who plan care and people who deliver it, or competition between people who deliver it. Also feels to me like a step forward. Do I have a full-blown evidence base for the change? We'll have a very clear playbook of what doesn't work, and I think quite a good understanding of how we've done things differently across the pandemic. And Ben, if I might, there was a question about whether I can justify some of these changes during a pandemic, and I did want to pick it up. The ICS working, or way of working during the pandemic, has meant we've been able to do things we simply couldn't have pulled off otherwise. The collaboration of our 3 acute trusts around looking after people in ITU, but actually in our general and acute beds more recently, our ability for local authorities to step into community discussions that the NHS really needs to have if we're to deliver a good vaccine programme and do it hand in glove with us, our ability to mobilise volunteers in a way that I haven't seen before and we really need to learn from. are all things that I think are the bedrock of an ICS. So I fundamentally believe that whilst I didn't wish to do this during a pandemic, it is in actual fact accelerated the very principles we've talked about this evening.
Thank you, Andrew. On Gay's point on the evidence, of course, we are, health service leaders are working in an uncertain world. But what I would say, Gay, is that, that those local health systems in England and internationally that seem to have made the greatest progress do seem to have done it through the sort of model of partnership working and innovation that we're trying to develop across health, local authorities and the voluntary sector. Andrew, you disappeared rapidly, but I was going to ask you one quick follow-on question. How will commissioning work in the future? How is commissioning changing?
So if I might be so bold, I'm not sure it is. Commissioners are changing. We're not going to see commissioners as a separate entity of people that sort of pick up the phone or email other people and ask them to do things. So commissioners are going to change. We're going to disestablish a CCG. It simply won't be here anymore. And we're going to ask our staff, who are very skilled at planning health and care services and understanding the needs of populations, to work in a multidisciplinary way with our providers who deliver frontline care. I don't think commissioning, as I define it, is going anywhere. I define it as having a relentless focus on the needs of a population, then finding out ways in which you might improve that and finding people who are willing to do it at the right scale. Now, what I would say is that we have been, in my view, overly focused on institutions and what they do or don't do, and not really been forcing the issue on what they might do together if they come together around a population. I've already said we've been pretty siloed in commissioning, so we've done health commissioning rather than health and care commissioning. So that will change. But this idea that we'll stop planning services and stop trying to base it on people's needs absolutely is going nowhere. Final point, Ben, and you may have more to say on this than me. We've gone for a couple of decades where competition and a sort of a reward for the amount of activity you do has been the way to drive change, and let's be clear, it has, and a lot of improvement. What we're entering now is to say, well, has that gone far enough? Is that the incentive that people need to work together? And at the moment, I'm very focused on value-based commissioning, outcomes as opposed to how many things you do. And so again, we've got another change. Commissioning generally, though, is here to stay. The way in which we do it is fundamentally going to be different.
It strikes me, Andrew, that that point you mentioned is really quite critical, that some of the tools that were top of the toolbox, at least in the past under previous health secretaries and administrations, such as competitive tendering, the purchasing, the market making aspects of commissioning. Those levers, it felt, were top of the toolbox a decade ago, and my hunch is that we're putting them a little bit to one side and focusing instead on partnership, the vision, the ability to pool our resources and insights as ways to drive improvement.
Ben, do you mind if I just say one more thing? I'm a little bit concerned that we are giving a set of presentations and answers that, whilst being absolutely honest and perhaps are dishonest in one way, and that's that I don't believe we will have seismic change on a particular day when the bill is passed. I think we are on a journey where we're trying to seek a different way of doing this over time. So I just want to emphasise that I don't think there's a magic. We were talking very much, I can see in the chat, about different structures in the health service and the day in which they do or don't exist. I think we're on a continuum here, which I'm quite proud of in South East London, where we're getting closer and closer over time to something that feels like a joined up focus on our residents as opposed to the institutions that treat them.
Super, thank you, Andrew. Now there is a question here on how the ICS will communicate and engage with local people. And Rosemary, I was wondering if you could come in on this and we could draw on your expertise.
Thanks, Ben. Can you just repeat the question for me? Sorry.
So how will the ICS keep communicating and engaging with local people?
Well, I think there's a range of ways we can do it. And we've already seen in the chat that not everyone is in IT or uses IT, because clearly using social media and the website will be a clear way of getting information out there. We also need to look at having stakeholder bulletins and using partners' newsletters and bulletins and getting information out in some of those ways in terms of putting communication out there. And I know a lot of the local authorities, and I live in the area myself, I get a quarterly newsletter through my door from the local council. So we need to look at those kind of ways of communicating. In terms of engagement, well, Anu's already spoken about a number of the ways that we do that, but I did want to draw attention to the fact that we need to work with local community groups and trusted organisations and go out to where people meet and congregate and meet people in their space and hear and have conversations with people directly to really understand what is important to them. So I think it's a range of ways, and we will be looking to grow that as well. So also welcome suggestions from people for what would work for them and their communities as well.
Super, thank you, Rosemary. We've got quite a big piece of work, haven't we, over the next few months to produce our new website, to develop materials that explain this new system in ways that make sense to the public, people who are not steeped in NHS acronyms. And I think, am I right, we're also thinking about what sort of platforms can enable ongoing discussion and sharing with the public.
We are developing a new online engagement platform, Let's Talk Health and Care in South East London, which whilst it is online, we want it to be, and it will be, more engaging. So less words, more visuals, more films. We can put up animations, we can put up talking heads as well. And that's a way of people giving their views, which is beyond a survey. So we can have open and closed chat forums as well. So people can respond to other people's views and thoughts, and we can do quick polls. So we're hoping that we can grow that so it can be a lot more interactive and people can spark off other people as well. I think people like that. They like to sit, you know, it triggers ideas. So yes, that will be a way that we will be developing.
Super, thank you. I can see Richard eager to wrap up. Richard, there was one last question I was hoping to cover before we hand over, which was how will you involve and work with voluntary and community organisations? Very quickly, as I hinted, I see patients and the public and the VCSE as the kind of the superpowers, the secret weapons that we have to think really creatively and differently in terms of how we deliver services. I'm just astonished by, you know, things like peer support models in mental health that find a completely different but really successful way of treating people or supporting people with mental health problems. So I think we're working at this on a number of levels. My colleague Jessica is convening a VCSE group that meets regularly to talk about how the VCSE will have a strong voice at the level of the partnership. There'll be a VCSE representative who we will fund to bring the voice of the sector to the partnership, but also fundamentally that the representation of VCSE colleagues in our local care partnerships is going to be critical, because that's where health, social care and the voluntary sector will be able to work together on really, really interesting new models of care. And on that note, Richard, I think before we hand over to you, we have a last poll to see if we've improved or reduced people's understanding of the ICS. So, Rosemary.
Thank you, Ben. If we could put the do poll link back in the chat. For those of you who are here at the beginning, we asked these two questions. Do you know what the ICS is? And do you know what it means for you? To take a temperature check at the beginning of the meeting. So can I ask you to either click on the link that's in the chat or cut and paste the link into a new tab so that we can see what your answers might be to that question now. So we've got 100% there, but we don't yet know how many
I think stop at 3 people,
responses.
Rosemary. Come on.
Yeah, sorry, I can't read that white on the green very easily, Richard. So let's see how that moves as more people click on that. And I'm glad to see, Ben, that they're not all your responses. Just for clarity, we had at the beginning, we had the final result was 73% said they knew what the ICS was and 27% didn't. And so we've still got, let me see how many people we've still got on the call. We've still got 46 participants. So if other people want to click in on that do poll to see whether we've broadened your understanding of what the ICS is. We've got up to 9. We'll keep the do poll up there, but we'll move on to the second question. I can see that JF has put no to the question in the chat. I don't know if you can go on the link that we've got a few more there. Well, still only 9 responses. So we've actually, I need to compare how many numbers we had in the first poll, actually, which I didn't note down, so my apologies for that. So we've still got a way to go in explaining what the ICS is, I think. What it means for you, I think, is a trickier question, and that's where we've got much more room to have conversations with local people and what the ICS means for them. So we've got 10 responses of, so 40% of people, so 4 of the 10 respondents so far say yes, they do know what it means to them, but the majority, 60%, don't know what they mean. That is a little shift in the percentage from the when we asked the question at the beginning, where we had 18% of people know what it meant for them. But again, I didn't note down the numbers, so my apologies. And I can see from some of the questions in the chat, the comments in the chat, that people are still confused. So I want to reassure people that this is the beginning of conversations that we will be having with local people, and we will hopefully clarify and grow our understanding together with you about what the ICS is. So thank you for that, and over to Richard.
Okay, thank you, Rosemary, and thank you all for your time tonight. I think it's been really good. It's been really interesting from my perspective, particularly in looking at people's questions. Now, a couple of things I'd want to say at the end is, first of all, we will get answers to all your questions. The ones we haven't answered tonight, we'll make sure we get out. I would like to reinforce a little bit of what I said at the start and what Andrew said, is that this is a big change and an important change. But in and of itself, it will not answer all the specific questions that you're posing tonight overnight. Yeah, this is a process we're going through. I genuinely believe it will improve what we do and how we do it, but don't expect it to deliver everything overnight. Keep engaged in this. Yeah, it is really important to us that we're trying to do this very differently than before, and we need your engagement on that. There are a number of comments where people say that this is still quite complicated. And I'm sort of in two minds on this. In one way, when I talk to colleagues in the NHS, they tell me this is very complicated compared to a market-based system where someone commissioned, another set of people provided, and the providers competed with each other. And in creating a partnership with multiple accountabilities, you're complicating stuff. I can sort of see that from within the NHS, but from outside the NHS, frankly, that's what most people have been expecting us to do forever. You know, they expect us to work together. They expect us to have a single objective to improve health and care, and they expect us not to focus on our institutional priorities. So I think there is a potential difference here between what we may think from the inside sometimes and what people say from the outside. But thank you for your time. I mean, it is a lot for people to give up between 6 and 8 o'clock on a Wednesday evening. That has been really beneficial to us. Thanks for your help, and I hope we can continue engaging into the future. And at that point, I think we close.